Great. Good evening, everybody, and welcome to this first Euro Intervention on Air, EIJ on Air, hashtag on X of 2024. I'm Nicola Ryan, and I'm an interventional cardiologist from Aberdeen in Scotland. And it's my great pleasure this evening to be accompanied by Thomas Fluscher, who is the senior author on the recent consensus paper that we're going to discuss. So the paper up for discussion this evening has recently been published in Euro Intervention. And if you haven't had a chance to read it yet, I really strongly encourage you to read it. It is a consensus paper about chronic total occlusions. However, it's written for all cardiologists, particularly for cardiologists who evaluate these patients in the clinic, in the wards, in the hospital, and for all of us to understand who benefits from referral to expert CTO operators. So the topic for discussion this evening is evaluation and management of patients with coronary CTOs considered for revascularization, a clinical consensus statement of the EAPCI, EACVI, and ESC working group on cardiovascular surgery. So welcome, Professor Fluscher. It's a great pleasure to have you with us. And would you like to start off the conversation by giving a brief overview of your consensus statement?
Yeah, delighted to be here. Thank you very much for inviting me. We are quickly looking at the paper as such with really only 3 slides. And I have to make sure I can open it. Okay, can you see it now?
Yeah, that looks perfect.
All right, so that's the title that Nicola already told you. It's a big group. Alfredo Galassi is the first author. I was delighted to coordinate that. We have imaging people that are interested in imaging and interventional cardiology and surgery to really get all the perspectives to it. And as you pointed out properly, this is really a chronic total occlusion considered for revascularization. We're not really talking about all the technical aspects, but more how do we actually encounter patients with chronic total occlusions. And of course, they can have stable angina, and we evaluate them, and we see that they have a chronic total occlusion. We would send it to an MDT and decide what to do. And of course, today we can do PCI, often very successful today and quite safe. We could send the patient to bypass surgery or just use anti-anginal drugs because often they have angina. But they may also have dyspnea, as shown on the left, because this is an angina equivalent, as you know well, or they could present as heart failure, and we look at this. Then, of course, there's ACS in the context of a multi-vessel disease where you have an LAD culprit lesion, for instance, and the RCA would be occluded, a patient that had cardiac arrest and has been resuscitated, most commonly without ST segment elevation, like in the arrest trial. And then there is an angiogram done, and you see this. Then also, patient can present as type 2 infarctions. They have a chronic occlusion. They are bleeding severely. Their hemoglobin drops to 7. And of course, then they have ischemia. They could have postoperative hypotension. They could have fast VT or more commonly atrial fibrillation. So all kinds of that. And then finally, we have all these beautiful modalities to see the heart. And the more we see, the more we find. And obviously, when we do checkups with a CT scan, this is a finding that's not so uncommon. But you also see on the lower right that, of course, we look for ischemia rather than just occlusion. So when we look at when we have a CTO detected, then, of course, the symptom evaluation is important. Angina is crucial because this is the major target for CTO revascularization because the outcomes in terms of mortality or infarction is not so clear, but it is clear that angina is improved, possibly dyspnea, if at all, a angina equivalent. So if you have angina and you find that and you have signs of ischemia, Then, of course, we would go for revascularization, and often preferably PCI because it's less invasive for the patient. If not, then we look at the left ventricular function. If there is normal left ventricular function, no angina, probably not a huge benefit. If there is impairment of left ventricular function, this can be considered, but we will discuss what this means after the REVIVE trial. And of course, here, when we go to the heart team, we have to distinguish between isolated CTO, CTO in the context of multivessel disease, and CTO with previous CABG. And here, of course, the cardiologists sit together with anesthesiologists, cardiac surgeons, and imagers that are extremely important to tell us whether indeed this myocardial segment served by the CTO is really vital and exhibits ischemia upon stimulation. So we look at the CTO complexity, CTO score, the JCTO score, which looks at the lengths and the morphology of the occlusion. And then local PCI expertise is important. Porcelain aorta is not very favorable for surgeons. And of course, overall surgical risk with CTS score, and Euroscore, although not terribly precise. And of course, frailty that would speak more for PCI. So we have these different options. And of course, we can also, if we want, consider medication. If we believe that it's a non-LAD occlusion that maybe is not terribly important for the intervention. And is just the score for those who need a short reminder. It's the blunt proximal cap, not very favorable. Calcification, also not so favorable. If the bending is very, very more than 45 degrees, lengths of occluded more than 20 millimeters or 2 centimeters. And of course, if you failed previously, that's not perfect. So this is what we wrote together with all these experts. And so it is really a team approach. And then decisions have to be made on what to do with it. That's the content.
Super. That's a really nice summary of the paper. I think one thing that I come across quite frequently, and I think most of us as interventional cardiologists do, we have a patient who has a CTO and we say, yes, technically I can open it, but the patient doesn't present with a classical ischemic type of a chest pain. And something I think we often struggle with is the patient has dyspnea, but is their dyspnea because they've deconditioned? Have they lost their fitness? Have they gained some weight? Are they subjectively thinking I am as okay as I was last year, but realistically they're doing less? I really liked in the paper you've suggested that these type of patients should have an objective assessment of their functional capacity. Do you think we should be scanning them? Should we be putting them on SPECT? Should we be MRIing them? Should we be getting them to do a treadmill? Obviously, I think a lot of it will depend on your healthcare system and your resources, but how would you approach a patient like that?
Well, I think currently we still think that if you have chest pain, you want to see ischemia to make sure that this is really cardiac in nature, because people have all kinds of chest pains that maybe are not very suitable for an intervention. And so that's why we involved experts in MRI, in nuclear, and in echo. And basically, you can do, as you know well, a stress echo, you could do an MRI or a PET or a SSTMIBI perfusion scan. And it depends a bit on the local expertise. Of course, in the UK, MRI is very popular. And Sven Plein actually showed that it's possibly at least as good, if not better, than nuclear technologies. So where I work at the Brompton, we mainly do MRI. Stress echo also very good. It depends a lot on the operator. And so I think you have to look at the local expertise. The good old exercise test is not as bad as we think, because if you can really demonstrate angina during exercise that is relieved when you give nitro or you stop it, is also reasonable indication if you have no other top imaging modalities available.
Great. And I think, CTO has obviously struggled with a lack of randomized trials, and we obviously have the 4 trials, 3 of which showed the Euro CTO, the Impactor CTO, and they showed benefit with regard to symptom relief. None of them have shown benefit with regard to long-term MACE. And obviously, Decision CTO had all its limitations, but showed equivalence. How do you address your colleagues who say, I'm not going to refer this patient for a CTO. I don't think it's going to give them any benefit. Do we come back to, we're not looking at long-term MACE, we're looking at the quality of this person's life?
Well, this is, of course, a crucial question. But first of all, I would say that symptom relief and better performance in everyday life without taking tons of tablets is also something important. If we don't consider symptoms, we can close rheumatology and other departments right away. But we're very fixed on mortality because cardiologists always want to save lives. But symptoms are equally important in quality of life. And of course, it will be tough these days to demonstrate a mortality benefit. We would probably need huge numbers because the event rate in stable patients, not in those that present acutely, is actually quite substantial. And if we have an event rate of 3% per year, we need 20,000 patients or 15,000 to convincingly demonstrate the benefit. And that's, I think, very unlikely to happen.
And I think we also run into the issue of patients who are very symptomatic from their CTOs and have been referred to expert operators often have a reluctance themselves to enroll in a trial for fear that they might be randomized to medication alone, and they really feel the benefit of PCI will improve their quality of life. You brought up earlier in the discussion LV impairment in patients with CTOs. Obviously, we know any PCI in a patient who has an impaired LV, you're increasing the jeopardy of the procedure, and particularly in these complex procedures where we are increasing the risk. And BESIS didn't show us a benefit with regards to LV improvement or looking at the sub-studies for arrhythmia. We haven't seen a benefit. Again, are we coming back to risk, benefits, quality of life of these patients? Or do you think there might be a subgroup of patients that we haven't identified that do actually benefit in terms of LV improvement with revascularization?
Well, of course, the BESIS, the REVIVE trial was a big disappointment, wasn't it? And not all patients had angina. The angina number, don't have it quite in my brain at the moment, but it was quite low to my, as far as I recall. So this is one question. If you really have quite significant angina, do the results of REVIVE apply or not? And I mean, overall, today, this is a safe procedure in experienced hands. So I would really base it on symptoms because outcomes, as you know, and as you just mentioned in the REVIVE trial, was not positive. Now, when we look at Stitch, this was initially also not positive. And then in the 10-year follow-up, it was. Now, you can always discuss whether, these patients that have been enrolled at the time, this is a long time ago, are medically treated as we would do it today. But it shows that possibly the mortality benefit comes rather late and not so quickly. Indeed, coronary disease is a decade disease. It's not a month or 1 to 2 year disease. So to show differences in the current context is probably not possible in the framework of a trial that runs 4 years, something like that. And so there is a new trial planned, Stitch 2 or whatever they call it. don't recall exactly the name. So we will see what, but this again will take a long time to get a response. And we have to consider also that these trials always select patients quite substantially. And so what we see in everyday life are not necessarily the ones that are recruited in a trial. So a little bit of judgment call by an experienced physician cannot hurt in this context.
Yeah, I think that's always a good suggestion. See the patient and decide what the patient needs. I think we just have one question from one of our viewers. They've asked that in the context of particularly STEMI, we have evidence to say that people should be completely revascularized, and a lot of people then take that to completely revascularize non-STEMI patients as well. However, CTOs are sort of a relatively small number of patients in these trials. And what's your take on complete revascularization for patients who've had an ACS and have a CTO? Is it something you advocate for? Certainly, personally, it's not something I would do in the acute, immediate hospitalization. But I'd be interested in your thoughts on that.
Well, we
So
just
obviously with our questioner.
in September, the multi-stars trial that I designed with one of my colleagues. And there we actually asked to do an immediate or delayed revascularization, but this was not for CTOs. And even for that, some of my colleagues said, I'm not going to do this at 3 o'clock in the morning because I don't feel like it. And do it later on next day, 3 days during the hospitalization. Now for CTO, this is even more so. You wouldn't attack a CTO in the acute setting right away. Because of course, as I just mentioned, this J-score has to be clearly, carefully evaluated, and the approach has to be discussed in an MDT. But if the patient is stable, and today, patients even with STEMI have very, very good minor injuries. Usually the average ejection fraction is in the range of 50 to 60%. So this could be addressed in the same hospitalization, or patients are recalled. It also is a bit dependent on the healthcare system. So in some systems, the operators prefer to do it later on because they get a second case, and that is favorable for the institution. But for the patient, it's probably better if you wait a little bit to get all the inflammation settling down that an infarction is associated with. So I would suggest to do this within a 30-day period. While for non-CTO lesions outside the infarct-related artery, I would suggest to do it right away during the day, and that if the patient comes at night, maybe it's better to do it during the hospitalization.
Great, thank you. I think that's a very sensible and a very pragmatic answer, and I think it nicely summarizes your paper as a whole and the entire discussion we've had this evening. It's a very good paper. It offers very practical advice, very sensible advice, very pragmatic advice, where we look at the patient as a person. We don't look just entirely at their arteries, and we carefully evaluate whether they will benefit from CTO PCI. You're not suggesting that we do PCI or send patients for surgery if they don't have symptoms, if they don't have ischemia, if they don't have viable myocardium. But in those patients that do have symptoms, do have viability, do have ischemia, there certainly is a benefit. So thank you very much for joining me this evening. Thank you for your presentation. It was very clear. Your answers were very useful for everybody. And I really encourage all our colleagues interventional cardiologists, non-interventional cardiologists who see these patients in the ward, in the clinics, to download the paper, read it. It's a very helpful resource. Thank you very much.
My pleasure. Thank you for having me.
Brilliant. And thank you to everybody for joining us this evening. And we look forward to the next edition of EIJ On Air.
Thank you. Bye-bye.